Grand Round speakers today for our Grand Rounds on updates in medicine. So we have a trio of speakers who will all be giving us all some very interesting insights and updates in clinical medicine. The way this morning is going to work is we're going to have each of our speakers speak for about 15 minutes, and we'll follow that with 3 to 4 minutes of questions before the next speaker goes on. And we will just get started. I will introduce the speakers before they come up, and we'll start with Dr. Susanne Ajao. Dr. Ajao is an assistant professor in the Division of Infectious Disease here at Rutgers Robert Wood Johnson. She has roles in both clinical care as well as in medical education. She cares for patients in both the inpatient and outpatient settings with the focus on HIV, antiretroviral therapy, and infections in immunocompromised hosts. She also serves as the medical director of the Complex Outpatient Antimicrobial Therapy Program, the COPAT program, as we know it, at the hospital. Her research focuses on weight gain associated with antiretroviral therapy and its cardiometabolic implications with the goal of improving outcomes for a very diverse patient population. So please join me in welcoming Dr. Ajao. Oh, sorry, wait, CME code. Everybody goes to CME code, which is 31648, 31648.
Thanks for the introduction. For those who haven't met me, once again, I'm Susanne Ajao, and over the next 15 minutes, we're going to be talking about the most recent Infectious Disease Society of America IDSA guideline update on the definition and management of urinary tract infections. So starting off with the objectives for today, the goal will be to define UTI and asymptomatic bacteria very briefly, to distinguish uncomplicated UTI and complicated UTI, to apply the key recommendations from the most recent UTI guideline update to clinical practice, to select the most appropriate antimicrobial management strategies in the setting of UTI, and discuss the role for some of our newer antibiotics. So briefly going over asymptomatic bacteria and UTI, asymptomatic bacteria is positive urine culture irrespective of the presence or absence of pyuria in the absence of urinary symptoms. So think of a patient with positive urine culture, but they don't have symptoms suggestive of a UTI. UTI, on the other hand, is positive urinary cultures with corresponding genitourinary symptoms. Although the most recent guideline update didn't touch too much on asymptomatic bacteria, the treatment was reinforced as deemed not necessary, and it doesn't necessarily prevent progression to symptomatic UTI. In the next slide, we'll talk about some exceptions where you might want to treat asymptomatic bacteria, but for the most part, seeing a positive urine culture doesn't mean you have to reflexively treat. Treatment may actually increase the risk for subsequent recurrent UTI, and test of cure following successful uncomplicated UTI and complicated UTI is not necessary. Over the next 15 minutes, I'm going to put in slides from our institutional guidelines, which can be accessed in the bridge. And one of the ID institutional guidelines for UTI is also present in the bridge. This briefly goes over asymptomatic bacteria. Like I mentioned, you generally don't need to treat this. There's usually another reason why the patient is in the hospital, but there are some exceptions. Pregnant patients, prior to urological procedures about 30 to 60 minutes before, and in kidney transplant recipients, generally within the first 60 days after transplant. And the guidelines we have on the bridge goes over both oral options for the others and IV options such as cefazolin prior to urological procedures. This just goes over the evolution of the guidelines dating back to 1999 at the top, where the guidelines was released for uncomplicated acute bacterial cystitis and acute pyelonephritis in women. And then in 2010, the guidelines released treatment for acute uncomplicated cystitis and pyelonephritis in women. And 2019, there was an update on the management of asymptomatic bacteria. So what you'll find is really there was never a focus on complicated UTI, and the last time we got an update on uncomplicated cystitis was 2010. This is a guideline I'll be referencing today. It was released late last year. It's a guideline on the management and treatment of complicated urinary tract infections. So let's start off with how was complicated and uncomplicated UTI defined before. Usually there were 3 buckets. with uncomplicated UTI being defined as acute cystitis in afebrile, non-pregnant, premenopausal women with no diabetes and no urological abnormalities. Acute pyelonephritis was a bucket in patients who had signs of an acute kidney infection in women, and uncomplicated UTI was pretty much everyone else. The new guideline classifications on the right sort of simplifies it, and in all honesty, it's what we have been doing in clinical practice, where uncomplicated UTI is an infection confined to the bladder. So think localized bladder infection. And this can be in afebrile women or men. Complicated UTI is infection beyond the bladder. So now we're talking pyelonephritis, presence of fevers, bacteremia, catheter-associated UTI. The guidelines did not address prostatitis, epididymitis, and we're not going to touch on that today. So think simple. Infection confined to the bladder, uncomplicated UTI. Infection extending beyond the bladder, complicated UTI. And what the general gist of this is, unlike before, where a man comes in with a UTI and immediately is defined as complicated, it's understanding that men can have both uncomplicated or complicated UTI. So this goes over a bit more detail in terms of the clinical presentation and the population. So clinical presentation with uncomplicated UTI, once again, lack of signs and symptoms of systemic infection. We have our typical symptoms, dysuria, increased urinary frequency, urgency, suprapubic pain, but no signs that suggest the infection has extended beyond the bladder. That means no fever, no chills, rigors, hemodynamic instability, no flank pain, costovertebral angle tenderness. That sort of hints towards more of a complicated UTI picture where the kidney is involved. Population, once again, this can occur in females, males. Uncomplicated UTI can occur in those with underlying urological abnormalities, patients who are immunocompromised, patients who have diabetes. Recurrent UTI can be uncomplicated, and generally speaking, any patient with long-term indwelling urinary catheters, such as transurethral catheters, suprapubic catheters, patients who intermittently self-catheterize, patients with stents, percutaneous nephrostomy tubes, generally do not have uncomplicated UTI. We put them in the bucket of complicated UTI. This is a picture straight out of our institutional guidelines, once again can be found on the bridge. And for uncomplicated UTI, the preferred therapy on the right there is nitrofurantoin or a single dose of tubramycin, Bactrim or Keflex, and in the absence of alternative options, Cipro or Levaquin. If there is concern for resistant organisms based off the urine cultures, don't hesitate to consult ID where we can help guide with the appropriate therapy. Moving over to complicated UTI. So once again, this is infection that's extended beyond the bladder. So now we're seeing fever, chills, rigors, hemodynamic instability, flank pain, costovertebral angle tenderness. And once again, it's patients who generally have indwelling or chronic catheters in place, patients with urinary obstruction, urinary retention. The guidelines propose a 4-step approach to choosing antimicrobial therapy for patients with complicated UTI, and we'll go through the 4-step approach. So starting off the top, you have a patient coming to you with concern for complicated UTI. Your first step is assessing the severity of illness. Are you dealing with a patient who is not septic, a patient who's septic but without shock, or a patient in shock? Once you've gotten the severity of illness, the next step is then assessing what are their risk factors for resistant organisms, looking at their prior cultures. Let's say over the past 3 to 6 months or a year, have they grown a resistant organism that kind of hints towards what your first antibiotic choice should be? Have they been exposed to certain antibiotics recently that you prefer to avoid? Then the third step is assessing patient-specific factors. This is where do they have allergies that you want to avoid certain antibiotics? Any drug-drug interactions based on other medications they're on. And then the fourth step is then looking at your antibiogram, which we'll talk about later. Notice that when it comes to patients without sepsis on the far right, there's no additional benefit of looking at your antibiogram. The benefit more so may come in your patients who are septic. And what is suggested is trying to pick an antibiotic with a threshold of at least 80% susceptible in patients without shock, and picking a threshold of at least 90% susceptible when it comes to the antibiotic option in patients with shock. And we'll talk more about that in a minute. And just to briefly touch on the severity of illness, you can assess this also using your Q-SOFA score or CIRS criteria. The general gist of this is when it comes to choosing your empiric antibiotic choice, it's trying to balance antimicrobial stewardship with inappropriate antibiotic choice on the initial first choice, especially when the weight of making the wrong option is high. Talking about your patients who are septic and short, where you're worried about high mortality risk. And generally, when it comes to antimicrobial stewardship, our concerns are C. diff, resistance selection, microbiome disruption, which we know can occur with just that first single dose of inappropriate antibiotic choice. And then when it comes to that inappropriate antibiotic choice in that very sick patient, we're worried about undertreating, clinical failure, mortality risk. And what you see is this is where those 4 steps come in, the decision factors, the severity of illness, the prior culture data, host factor, host risks such as allergies, or using your local antibiogram data. This is from the IDSA guidelines. This is the empiric choices that are recommended. Starting off with patients who are septic, with or without shock. Your options are, this is what we generally use, our 3rd or 4th generation cephalosporins, carbapenem, piptazo, fluoroquinolones. In patients without sepsis, in terms of IV route, you notice carbapenem isn't listed there. More so because you necessarily don't need to reach for this on the get-go. Starting off with your 3rd or 4th generation cephalosporin, piptazo, or fluoroquinolones is ideal. And in patients without sepsis, where oral therapy can be appropriate, fluoroquinolones or Bactrim are a preferred option. On the right, we have alternatives where you might want to get ID involved when you start looking at beta-lactam, beta-lactamase inhibitors, additional aminoglycosides. But I just want to touch on the last row where it talks about without sepsis, the oral therapy. Augmentin and your oral cephalosporins, essentially those beta-lactam options are alternatives, more so because of a concern of just less efficacy when it comes to treating UTI and a question of the poor bioavailability compared with fluoroquinolones or Bactrim. When you want to start reaching for these antibiotics, you want to make sure there's no concern for source control, your patient has clinically improved. This is straight from our institutional guidelines treating complicated UTI. The empiric antibiotic therapy is in the second row, the second column. So for community-acquired complicated UTI, ceftriaxone is generally recommended. In patients who are critically ill, we're talking patients in the ICU, piptazo, or you can consider cefepime if they're penicillin allergic. And then if you have a history of multi-drug resistant organisms, maybe this is time to reach for meropenem or ertapenem. And then when it comes to oral step-down, levaquin, Bactrim are preferred choice, and in the right patients, sulfadoxine can be an option. Once again, if you're dealing with urine cultures growing very resistant organisms where meropenem is not an option, this is where an ID consultation can be helpful because we can help guide the appropriate therapy. And I just want to highlight with complicated UTI, you do want to avoid nitrofurantoin and fosfomycin because there's a concern they do not get adequate levels in the renal parenchyma. So this is our antibiogram. For those who haven't seen this before, this can be found on the bridge. It's generally a collection of all the isolates over the past year. Just to orient you, the column on the right lists out all the gram-negative bacteria that have been isolated, and the top row highlights the different antibiotics. And in the middle, it's more showing you the sensitivity ranging from 100% down to 0. And what I've highlighted here are 2 of our more common organisms isolated in the urine. So starting off with E. coli, if you follow that all the way through ceftriaxone, you see that the susceptibility is about 65%, and looking at meropenem, the susceptibility is 99%. So ceftriaxone is probably okay, starting this patient coming to the ED on the floors, but once you're dealing with a patient coming in with complicated UTI, blood cultures are cooking, they're on pressors, maybe it's time you reach to meropenem until you get culture data. The next question is, when is it time to switch to oral therapy? In patients receiving IV antibiotics, they don't necessarily need to stay on IV antibiotics the whole duration of treatment. As long as they're clinically improving, so starting off on the right, as long as they're clinically improving, assess for oral options. You can switch to oral agents as long as they're able to tolerate and you have oral options based on your susceptibility data. And generally speaking, 7 days total is fine for complicated UTI, even if bacteremic, as long as they're clinically improving and there's no concern for source control. On the other side, in patients who are not clinically improving, maybe it's time to assess for bug-drug mismatch, any unresolved source of infection. maybe it's time to reassess that complicated UTI diagnosis, and maybe you want to plan for a longer course. You probably just need some more time on the antibiotics. I'll finish off with some newer antibiotic agents for uncomplicated UTI. Due to time, I'm not going to go too in-depth into these options, but these are some oral antibiotic options that have been approved over the past 3 years. So starting off with pivmecillinam, which was FDA approved in April of 2024. This is approved for females with uncomplicated UTI. It does have activity against certain ESBL-producing enterobacterialis. Jagpreet was approved for uncomplicated UTI in females in March of 2025. And sulopenem, which is an oral carbapenem, was FDA approved in November of 2024 in females for uncomplicated UTI, and also has activity against ESBL-producing enterobacterialis. Moving on to complicated UTI, cefepime and enmetazobactam is a beta-lactam, beta-lactamase inhibitor. It's effective against ESBL-producing enterobacterialis. It was FDA approved for complicated UTI in February of 2024. Could have been a potential carbapenem-sparing choice for ESBL infection, but unfortunately, due to cost, it's no longer available in the US. IV fosfomycin, think IV formulation of our oral fosfomycin, is available. It's FDA approved in October of 2025 for complicated UTI. Also effective for more resistant ESBL-producing enterobacterialis. More particularly, FDA approved for susceptible isolates of E. coli or Klebsiella pneumoniae, and can also be a carbapenem-sparing choice. So in summary, if there's anything I want you to walk away from this presentation is knowing the new definitions for complicated UTI. Think infection extending beyond the bladder, and this can occur in either men or women. And the duration of 7 days of antibiotics can be sufficient for complicated UTI in the setting of clinical improvement. You don't have to go 10 days or 14 days like we used to. And on the bridge, our compared UTI and uncomplicated UTI guidelines are available, which I have highlighted in the picture. Thank you.
Thank you, Dr. Ajao.
And I'm happy to take any questions.
Questions? There's no question. Okay. Thank you. Thank you. This is it. Just. Okay, gives me great pleasure to introduce our next speaker. Dr. Jagpreet Grewal is an assistant professor of medicine here at Robert Wood Johnson in the advanced heart failure and transplant, and he's an advanced heart failure doctor and a transplant cardiologist at Robert Wood Johnson University Hospital. He completed his internal medicine training at Drexel, followed by a cardiology fellowship at Newark Beth Israel and advanced heart failure training at the Medical University of South Carolina. He's contributed to the field through research and national presentations and brings a strong commitment to medical education and multidisciplinary patient care. He's known for his thoughtful approach and excellent bedside manner, and he's dedicated to delivering high-quality, patient-centered care. So please join me in welcoming Dr. Grewal.
Good morning, everyone, and thank you for the introduction. So I'll be talking to you about missed opportunities, high-yield interventions in heart failure. So just getting right into it, as we all know, heart failure is a highly prevalent disease. About 6.7 million adult Americans have heart failure, with prevalence expected to exceed 10 million by the year 2040. The lifetime risk has increased to about 1 in 4 American adults in developing heart failure throughout their lifetime, so extremely prevalent disease. Regardless of your ejection fraction, mortality and readmissions remain similar. As we see here, 5-year mortality remains alarmingly high at 75%, with cardiovascular readmissions at 60%. And as you see, there's very little difference if you have HFpEF or low ejection fraction. Each heart failure hospitalization is a sentinel event in the patient's disease course. As you see, there's a tremendous impact on survival, with the median survival almost 2.5 years with the first heart failure hospitalization, and each subsequent heart failure readmission has a negative impact on their patient's mortality. So to see opportunities here at our system, we looked at heart failure admissions over a 6-month span. We kept the inclusion criteria of low EF or repeated admissions in a 1-year span. And applying these criteria, we found about 400 charts, and the mean age of the sample was 72 years. So our first step was to rule out where the heart failure service would probably not make a difference. And off the bat, 20% of these patients were already plugged in with the heart failure program. But just going down the other list of reasons, 14% of these patients were admitted for another reason. 7% of patients died or went on hospice care. 7% had a other terminal illness. 6.8% had dementia, 8.9% had end-stage renal disease, but I'm happy to share that in the past 6 months, we've done 2 simultaneous heart-kidney transplants, and so maybe that's something that we could contribute to those patients. And 8% of patients had substance abuse. Now, looking at the remaining patients, about 40% were left. We found that, about 26 patients had wide QRS, or they're entirely ventricular paced, so there might have been a role for cardiac resynchronous therapy. 26 patients could have benefited from AFib ablation, which would help with symptom management and possible heart failure hospitalizations. 38 patients could have benefited from a cardiomems, which is a remote pulmonary artery sensor, but I'll get into maybe all these patients could have benefited from this therapy later in the talk. And another 36 patients would have benefited from a MitraClip, which is a transcatheter edge-to-edge repair, which we'll talk about later in this talk. And another 10% would have benefited from following up with the heart failure service. So I'll go into some of these therapies and how the data is for the heart failure population. So we always talk about guideline-directed medical therapy. So we have 4 pillars of heart failure therapy, which we have 4 distinct classes of medication, each of which offer a mortality benefit. And when used collectively, you have a 73% reduction in mortality and a number needed to treat of 4 to prevent one death in heart failure. So really powerful classes of medication. We're familiar with medical therapy, so we'll talk about device therapy in this talk. So jumping ahead into the MitraClip, we have the results of the COAP trial. And just a quick refresher for everyone, the MitraClip is a transcatheter edge-to-edge repair of the mitral valve. So you basically just take similar to like a surgical alveoli stitch, you kind of fuse the middle leaflets of the middle scallops of the anterior and posterior leaflet of the mitral valve. So this was studied in the COAP trial where they looked at moderate to severe or severe secondary mitral regurgitation who remained symptomatic despite optimal medical therapy. And I'll get into the next slide why this is bolded and highlighted here. So patients were randomized to medical therapy or device therapy, and the primary effective endpoint was heart failure hospitalizations within 24 months. So as you see here, you have a dramatic decrease in heart failure hospitalization, almost a 50% reduction there. And to go along with that, there was a mortality benefit seen at 2 years. And with 5-year follow-up, the results still hold true. There was a continued decline in heart failure hospitalization, and mortality was better at 5 years. But what is really important to highlight, even in a controlled setting where patients were followed and in a medical trial where they're on good guideline-directed medical therapy, mortality remained alarmingly high at 57% at 5 years, even for the device group. So these patients still remain sick and need to continue follow-up with the heart failure service. So after the trial was done, the MitraClip is now being performed in many hospitals across the country, and we look at registry data, we see that there's really a disappointing uptake in guideline-directed medical therapy. We know the meds work, but for some reason, even in the registry, just 1 in 5 patients were taking 3 of the key heart failure medications that received a MitraClip. So certainly an area of improvement there. The MitraClip was studied in the European population, the Reshape Heart Failure 2 trial, similar fashion, which yielded similar results here. So it's a clear benefit with this device. So when we release or discharge a patient from the clinic or from the hospital, we tell the patient to look out for signs and symptoms of heart failure, look out for lower extremity edema, orthopnea, check your daily weights. We give them a scale and tell us to let us know, or go up on your diuretics whenever you feel a little more symptomatic. But we have a large body of evidence. We look at each trial that used this form of remote monitoring across 10,000 patients. There was no impact on heart failure hospitalizations. So really non-hemodynamic based remote monitoring does not really reduce heart failure hospitalizations. And to go further into that, our classic exam skills where we look for rails, look for edema, look for elevated jugular venous pressure on exam, really the sensitivity is 58%, and even radiographically, on chest X-ray, patients, a third of patients have no congestion on the X-ray, even with their wedge pressures above 25, which is really high. So our role should be focusing on catching these patients early when the filling pressures are increasing, where the heart failure syndrome starts. So we want to find people earlier before they decompensate with weight gain, edema, or further symptoms. And that's where the role of remote pulmonary artery sensors come into play. We love doing our cardiac catheterizations, checking out filling pressures, but doing that on a routine basis is not practical. So we have these sensors, which, on the left you have the CardioMEMS device, and on the right you have the Cordella. We'll talk about the CardioMEMS because that's what we implant here at Robert Johnson. But just to give a brief overview, this is a small sensor that's implanted into the pulmonary artery, and the patient goes home and lies on a wedge, as you see in that illustration there, and they transmit their readings to the managing clinician. And the clinician is able to look at pulmonary pressures and see if there's elevation. We can escalate diuretics, titrate guideline-directed medical therapy, and hopefully this is a trend that you see, like in this, on the bottom right, where a patient starts out with elevated filling pressures, and over time we get them into goal and keep them there. And this was studied in the Champion trial, where symptomatic heart failure patients, irrespective of left ventricular ejection fraction, were followed up for 6 months, and there was a reduction in heart failure hospitalization by 37% in a short period of time. So very, very effective device here. So that's where we get the indication for the CardioMEMS, which is symptomatic heart failure. It doesn't matter about the ejection fraction, elevated pro-BNP, and if they have at least one heart failure hospitalization in the past 12 months. I just want to talk about a success story that we have here at Robert Johnson. This is a cut and paste from the EPIC chart. As you see, we have a frequent flyer here. She has all the comorbid conditions. She has HFpEF, atrial fibrillation, COPD, obesity, OSA, and from I think about like a six-month span, she had about 9 admissions, 6 of which were for acute decompensated heart failure, 2 were related to overdiuresis. We push her diuretics as an outpatient. Her creatinine went to 5, or her potassium went to 2. She was implanted with a pulmonary artery sensor in May 2025, and since then she's had no heart failure hospitalization. So really, even a real world practice, this is very, very effective therapy. So getting into the advanced heart failure population, this is the patient with heart failure that no longer respond to medical therapy. As you know, we have a transplant and LVAD program, and in the year 2025 alone, across the country, about 4,800 transplants were performed, and about 3,500 LVADs, which, just a quick refresher, left ventricular assist device is a pump that is implanted in the left side of the heart and it helps circulate blood to the rest of the body. Now, as we all know, the prevalence of heart failure is increasing, but we kind of have a demand mismatch where there's more people waiting for hearts and supply is just kind of stagnant. And that's where the role of, mechanical circulatory support comes into play, as patients are waiting for hearts and dying on the transplant list. And, over time, we've had innovations in medicine, and, we have excellent 2-year survival, about 81%, with the current generation of LVAD therapy. And as you see over time, you start off at 8%, 24, 58, so it's just exponentially growing with current technology. And we have 5-year data where patients are living up to 60% on LVAD support. And 60% does not sound great at 5 years, but you're really talking about 100% mortality at 6 months in this patient population. So a really sick cohort of patients. So we talked about how this talk is focusing on the missed opportunities. We see that we have the CardioMEMS device, which essentially all symptomatic heart failure patients should benefit from. We have the MitraClip, about 26 patients in a short period of time would have benefited from, and of course, heart failure is growing in prevalence, and we have a lot of sick patients at this hospital. So, I think Dr. Goulden, our section chief, is coming up with a program where we can, get these patients plugged into the heart failure service quicker. Essentially focusing on the low ejection fraction patients who do not have significant comorbid conditions which would compete with their survival. So, I think this is something she's working on with the hospitalist, and we'll see if further information to follow. Thank you. If you have any patients that would benefit from CardioMEMS or heart failure follow-up, this is my contact.
Any questions for Dr. Grewal? Fascinating. No? Yeah.
Just to clarify, you're really doing reduced ejection fraction. What about patients? It's much more common now that have preserved ejection fraction heart failure. What do you do with them?
So the question is, what about the HFpEF population? Yeah, so they're very challenging to treat because really HFpEF's a disease of comorbid conditions, right? Obesity, AFib, so CKD. So far to date, we don't have any medical therapy that targets mortality. We have, we have the non-steroidal MRAs, the like finerenone, which there was a reduction in heart failure hospitalization. Then we have SGLT2. I think the focus is really just managing the comorbid conditions and trying to keep these patients out of the hospital where CardioMEMS may come into play. For example, that patient I had illustrated, but yeah, really challenging patient population, and we're really limited with advanced therapy options with them. It's just kind of focusing on medical management.
Any questions?
Yeah.
For the CardioMEMS trial, you showed like a reduction in hospitalization. They also show a reduction in mortality at all?
So there is some, I had a little bit of a limit here, but there is some data showing that you can, if you keep these patients in range with their pulmonary pressures, that their mortality is better, which kind of makes sense, right? If they're not decompensating, they're going to do better than the general heart failure patient. So yeah, I didn't include that slide just because I didn't think I had enough space, but yeah. But it wasn't in this trial, it was kind of like registry follow-up, so it's take with a grain of salt.
Is this preparation for transplant?
Sorry, can you repeat the question?
Is this procedure a preparation for future transplant?
Yeah, so that's a great question. So it's good to know if these patients are decompensating. You kind of have a monitor to see which patients are, their hemodynamics are stable versus the ones that are not staying within range. So it could be something that kind of gauges who's going to decompensate quicker than your average heart failure patient.
Online is asked, is insurance coverage the same across the board for CardioMEMS?
The question was about insurance coverage.
Yeah, so it's getting better. So if you have straight Medicare, you can go ahead and implant the device without prior authorization. If you have commercial insurance, you have to get a prior auth. So before we were just kind of limiting this to patients follow up in the clinic, and then we get the prior auth and implant it. But now if they have straight Medicare, we can do it as an inpatient and go from there.
Great, thank you so much. Okay, our next speaker, Tom, you can do this when you get up here, is Dr. Tom Nahass. He's Vice President of Health Informatics at Robert Wood Johnson Barnabas Health and a clinical assistant professor at the medical school here. He trained in internal medicine with us here and then completed a fellowship in critical care medicine at Memorial Sloan Kettering with additional training in clinical informatics. His work focuses on real-world application of AI and EHR-based tools to improve patient outcomes and health system performance. He's led large-scale initiatives across multiple hospitals that have reduced mortality and enhanced clinical care delivery. He's also been recognized as one of Becker's Rising Stars, Healthcare Leaders Under 40. So please join me in welcoming Dr. Nahass.
Thanks. It's good to be here. Also, just like to shout out to Happy Administrative Professional Studies. So, thank you for everybody. Today's talk, I'm just going to go through quickly kind of the evolution of early warning systems and how they were developed, and ultimately land on how AI is enhancing that. Machine learning processes are enhancing what we have in our systems. Go through that stepwise process, and then talk about what we did for the health system in our 11 hospitals with the deterioration index rollout. So no relevant financial disclosures. So really the failure to rescue, and the reason early warning systems were born was, can we shift it upstream to find these patients that are deteriorating quicker? And so it's rarely instantaneous deterioration, and the systems are in place so that we find patients who have that slow burn, not really the ones that have a immediate VT arrest. And so we try to shift that detection of those patients that are slowly deteriorating and getting out of homeostasis upstream. And so that requires proactive physiologic monitoring. And so as the EHR has come onto mainstream, we're getting more and more data in real time in order to detect these changes. And so really it's born out of pathophysiology. And so if you have a diabetic patient, for instance, who is going into DKA, their body tries to buffer their acid, you have this slow process as they forget their insulin, and then your body increases the glucagon and then develops the acidosis, and your body is constantly trying to maintain that homeostasis, and eventually you reach a point where your body can't compensate and you end up in a coma. And so really the concept of these early warning systems are, do we have those detection tools that we can identify these things upstream? And because we're monitoring their blood work as well as their vitals pretty continuously throughout their hospital stay, you can ideally find ways to intervene earlier. And so we want to avoid that overt vital sign collapse. And so really the three epochs of the early warning systems have been from a reactive perspective with vital sign heuristics, and then we go into adding in the laboratory values. And then ultimately where we're at now is implementing AI-driven or machine learning algorithms to really detect small changes earlier than the overt vital sign collapse. And so briefly, we'll go through a few of these. And so Muse, we know we used to use it here in the hospital before Epic. It's 5 different vital signs: SBP, heart rate, respiratory rate, temperature, and level of consciousness. And this was a nurse-driven protocol. And we typically see the predictability for these tools for deterioration around 0.7 or 0.74. So you get a pretty generic, hey, this patient's sick. But again, it happens when the patient gets evaluated and their vital signs are evaluated. And so when you have a score of 5 or more, you see a 5 times increase in mortality, a 10 times increase in ICU transfer, but it's fundamentally reactive. And so what we end up seeing is there's a number of different false positives, largely related to telemetry kind of errors and various different factors that may not be relevant. And so that's where the News 2 score came in. And so the News and the News 2 score, they added in the oxygenation. Oxygenation obviously is a good thing to pay attention to. And this gave a little boost to the performance up to about 0.8. And so in the studies that have been shown, it's between 0.76 and 0.83 for deterioration. It outperforms the Muse for outcomes of death or cardiac arrest or ICU admission within 24 hours. But again, it's another reactive tool, and so it requires that nursing documentation. You have less false positives because you're now able to take into account the oxygenation in addition to the respiratory rate, but it's still error prone. And then as we move into the next kind of epoch of the tools, eCart was developed by Edelson probably in the early 2010s, and they added in 33 different variables that they looked at each individual laboratory value and showed whether or not it had an impact on the survival. And so based on those variables, they got increased performance up to 0.89. And right now, the latest study by Edelson last year, maybe 2 years ago at Yale, where they compared all of these tools, this was the leading performer. It shows a lead time of about 11 hours before the deterioration, and whereas News was 8 and 5 was for Muse. And so, as I mentioned, it outperforms the other tools, including the deterioration index, and we'll get into a little bit of the limitation. But the ease of integrating within Epic is a little bit challenging, and that's really the limitation of the tool. But of note, what's interesting is this was one of the first algorithms developed that is FDA approved as a software as service. ChartWatch brings us into the next phase of epochs, which is the machine learning enabled models. And so this was a multivariate adaptive regression splines. it was set so that the positive predictive value was about 1 in 3 patients where it fired on. These are actually deteriorating patients. In the study, it showed on a general medicine ward an improvement in 26% mortality reduction for patients that weren't going to palliative care. And it showed an absolute risk reduction of 0.69. It also, of note, they looked at the code status changes, and so this made providers more aware of whether or not this patient was at risk of dying. So it enabled further clarification of goals of care. So the study was a little bit limited in the sense that it was limited to the general internal medicine ward, but improved outcomes weren't seen when they rolled out it house-wide. And again, it's not easily integrated. And I'll just quickly touch on a sepsis-specific model. TRUES is a real-time model, but they use a adaptive Cox regression model to identify patients at risk of sepsis. They showed an improvement in absolute risk reduction for mortality as well as administration of IV antibiotics by about 2 hours. And so we're currently evaluating this, but it is limited in terms of easy integration. This is just a summary of those tools. And so getting into Epic's deterioration index, again, this is a machine learning enabled model. That's a logistic regression. There's 17 variables that it's continuously monitoring. We have it set in our system to every 15 minutes to look at a variety of different factors. Ours is a modified deterioration index. We don't actually include the GCS because we found it has too many alerts. But consistent with the performance that other studies have seen, 0.685 to 0.8, our performance when we localized it was actually 0.87, which is why we decided to move forward with these. And so what did we do? So we have 12 hospitals in our system, 11 of which were on Epic when we rolled this out. And so this was a study of 23,000 patients that were considered high risk, which are patients that had a score of 60 or above. We looked at it from a 22-month period of time, and we compared the hospitals at the time at which they went live to the time they had beforehand. So we used a pre-post for every hospital. So we had the background data as well as the data once we rolled out our intervention. And so then we aggregated it across a variety of different teaching sites, teaching community centers, and community teaching as well. We had a sick patient population, as we know, average age of 71 years old, as well as a high comorbidity burden. And so really, when we look at what we used to have for Muse, it was constantly alerting on low-level fluctuations, whereas now we have this gate at 60 or above, and this is the one that will then send the threshold push to the rapid response team directly. And so we spent a lot of time initially trying to refine how many alerts were actually given. And so our intervention was really, we're calculating every 15 minutes. We have less than 30 is a green, 30 to 59 is a yellow, and 60 and above is a red. And once you hit 60, it sends a direct alert to the rapid response team. And we spent a lot of time, like I mentioned, on the algorithmic suppression. So different things like ICU, comfort care, or recent alerts that may or may not have been triggered. And then we ultimately send it to the rapid response team. And our workflow intervention was that they have to respond to the bedside. And so as you guys have seen in the EHR, we have patient list columns, but we have an escalating presence where green is just on the patient list, yellow is on the patient list and the storyboard, and then the red alert adds that push notification. And so we started here in New Brunswick in May of 2023, and that's where we really refined the alert so we didn't push out too many errors, I guess. And so we ultimately landed on expanding to the next 3 hospitals in the system. But what was important at this time, we drafted an AI guideline at that time to say and suggest that this wasn't a mandate for you to use, but it also gives the clinician the end autonomy to say that it is or is not relevant. And so that was approved at all the CMOs. And so we had a lot of leadership and stakeholder buy-in from leadership as well as from the boots on the ground and the rapid response team as well. And so we spent a lot of time refining the alerts, and this just shows that in the patient population, only about 46% received the push notification, but we still studied the ones that scored above a 60 to identify whether or not that had an impact on their ultimate outcome. And so what did we see? We saw a reduction of 18% in our risk-adjusted odds of inpatient mortality across the system, which is an absolute risk reduction of 4.5%, or a number needed to treat of 23 patients. So evaluating 23 patients that have a high-risk score with RRT saves 1 life. And what we then looked at was to identify if that was a true effect. We took a look at, for a sensitivity analysis, the patient population that is considered similar between 55 and 59 and 60 and 65. And that's the just above and just below analysis to see if whether or not the mortality benefit was more in the patients that received the push alert. And what we saw was that it was consistent with our overall risk reduction, although it didn't reach statistical significance in that patient population. The study wasn't powered for that, but it was reassuring. And then as we stratified across hospital type, we have patients that are, we saw risk reductions in all subsets of the hospital types. The only one that didn't reach statistical significance was a non-teaching hospital where there weren't as many patients. And then there were 2 hospitals individually that didn't adopt the tool as robustly, which actually saw an increase in their mortality from the pre to post. Finally, our last sensitivity analysis was really a binning analysis to see if there's other additional opportunities. And so between 60 and 80, we saw the highest level of reversibility, whereas above 80, we saw patients that had a diminished rescue effect. And so we think that the higher you go, if you can get to them earlier, that's really where the intervention has the most impact. And so if you can get them to the ICU earlier, you have a better chance of reversing what's going on. So really it comes down to the partnership between man and machine, which is really, augmenting the ability to watch over a bunch of different patients as well as their clinical factors, and then have the boots on the ground be able to put that into clinical context and use it. And so really as we move forward with our AI journey, it's really meant to augment our intelligence and level us up rather than replace. And so that's all I had. Questions?
Questions for Tom?
You just mentioned that there's some challenge when you integrate the app. Can you give more perspective? What does that mean?
Sure.
Sure.
So the question was about challenges related to integrating within Epic. And so there's when you take an algorithm from, in silico to the Epic platform, the challenge is that you have to have mechanisms to monitor the drift, different reportings, different dashboarding. And so the comprehensive package that Epic gives us is the whole with different reporting availability, dashboarding tools so that you can monitor those things. Whereas the vendor models that come out or the homegrown models, you have to create all of those things as well. And so taking those additional resources to build that package to monitor and identify, whether or not it's firing appropriately, et cetera, is much more challenging with a vendor model. And so that would be the limitation mainly.
Is that doable, or is that feasible, or they just stop right there? They're not going to move forward?
Well, anything's feasible with enough time and resources. So I guess the question is, it has to, what we end up doing, and when we compare these things are, is the additional benefit above an Epic vendor model worthwhile to spend those resources to build out that custom mechanism? So that's really the work that needs to be done. So.
Was there any false alarm? And adverse effect on patient treatment?
The question was about false alarms and treatment. So with our sensitivity and specificity, we're right now currently sitting at about a 5% false positive rate. So our specificity is actually very good, 95%. And so it's not firing on a lot of patients. Now, in terms of patient harm, we haven't heard of much in terms of that, but it's reasonable to think that, I'm not sure. You end up with a patient that's being seen more often and getting another set of eyes. So at a risk of false positive, somebody else is identifying them as potentially being sick.
There's a question.
Is that if you get a false alarm, because if you have AI, you also need an AI nurse or doctor to work with it. Is there any miscommunication between the two that could hurt the patient?
Could you repeat the question, please? Sorry.
I said that, if you have an AI, you also need a nurse that who is an AI that understand those things and acts properly. So sometimes, like these days when we don't have that AI, sometimes the nurse could misjudge and harm the patient.
Yeah, 100% agree. I think understanding how these tools work and what goes into the evaluation is paramount as we move forward with AI, because you can't just trust something blindly just because it says this patient is sick. And so, for instance, we have false positives that fire if the respiratory rate is put in as the heart rate. So you have a respiratory rate of 100, and you don't want somebody rushing to the bedside to intubate a patient because of their heart rate in there, right? So it'll turn red, but red doesn't mean, it means evaluate the patient. I think at the end of the day, we have to still be, clinicians and appreciate the context of the patient as it relates to what it is. Yeah.
Oh, thank you. That was good answer, sir.
Thanks.
Besides mortality, could it have an effect on length of stay?
Sure. Yeah. So we're currently looking at that. It does have a slight effect on length of stay, but it also has other secondary effects and outcomes such as increased palliative care discussions, DNRs, goals of care discussion, et cetera, discharges to hospice. So,
Is there any extra expense for the insurance companies or the hospitals that they may not approve that?
No, I don't think so.
No, okay.
You alluded to data entry error. How much of this is automatic? If someone's on telemetry, for example, is that pulling in automatically, or we're waiting for nurses to?
Yeah, so we had
Tom, can you just repeat?
Yep, the question is how much of it is being pulled in automatically versus those that are being manually entered. And so the way our vital signs get imported is that there's unverified and then verified vitals. And so we only accept verified vitals. So the nurse has to click yes, import. So they're supposed to read it and enter it, but oftentimes, it's just, yes, they're there. So again, you sometimes have a patient with Parkinson's disease that, their vitals are errant, and so. But the rest, the labs and everything are all automatic. Thank you.
Thank you.
Yeah, sure. Can I end?